This recent article in the New England Journal is really important work because it pulls together data from hundreds of thousands of individuals across the globe. A key takeaway for all practitioners is that it's so important to focus on those traditional risk factors: overweight and obesity, smoking, hypertension, blood lipids, and of course diabetes, because they really are the major drivers, the causal risk factors for cardiovascular disease events.
Anything that we do for our patients has to incorporate education about how important it is to eat a healthy diet and be physically active.
Tell me a little bit more about your diet and how much do you eat from home versus from outside?
I cook mostly Mediterranean diet.
The Mediterranean diet is the diet with the most evidence to support heart health, so that's excellent.
A lot of clinicians don't know what advice to give because we're not taught this in medical school.
One way to frame discussions about the risk factors for cardiovascular disease is using the American Heart Association's Life's Essential 8 concept. It's really a nice way for patients to think about those things that are lifestyle issues and those things where they need to know their numbers and they need to manage those numbers with their doctor.
I find it most important as a teaching tool. I direct them to the American Heart Association's website and I say, please read about Life's Essential 8 because that's going to give you information about changes that you can make in your own life to improve your blood pressure, cholesterol, your sleep habits, your diet, your exercise, and so forth. The single most important thing you can do is the hardest, which is to start to eat from home more. That is a whole different way of living, and yet that's probably where you get the greatest bang for the buck. We can help people think through what that could look like for them. I have a lot of patients who are shift workers. You leave the house at 5 a.m., you don't come home till late at night. Okay, is there a possibility that on the weekend you can pick up a bunch of chicken and grill it and then you stick it in the freezer so that it's ready to put on your salad?
I start the conversation by how many times do you eat vegetables in a day? Trying to figure out where people are is key on everything, but if you can find a vegetable they like and then try to get them to eat that a couple times a week and then challenge them to try one thing that might be similar to it, it's just figuring out what people are willing to try. We talk about eating things that your great-grandmother would recognize as food. It needs to be an actual whole food product that might look like a plant or animal.
What I like to focus on with my patients is making sure that they are avoiding processed foods, particularly foods that are high in salt. Sodium drives blood pressure in everyone.
Where most of our sodium in our diet comes from is actually breads. Not something you would classically think of, but because of all the processing that goes into our bread products, that is a huge part of our dietary sodium intake.
At our blood pressure class, we also taste multiple different things like smoked paprika and garlic powder because people need concrete examples of how could I not add salt.
I don't think we could overestimate how important physical activity and exercise is. It literally helps people live longer, less depression, less dementia, less cancer, less heart disease, less stroke, less everything. The people who age the best, they're the most functional cognitively, physically, they're the people who walk every day. Doesn't have to be walking, could be dancing, could be hefty gardening. They do something physical every single day and they don't miss it. Moderate intensity is to the point where you can talk but not sing. If you can sing a song, you're not moving enough. And that's different for each person. Some people might have to run to do that. Some people might have to barely walk to do that. Whatever that is for you, get to the point where you can talk but not sing and try to sustain that over time.
We can dictate to the patient all day long, and they're not going to do it if they don't know how or if they're not motivated to do it. So taking just a few seconds to elicit from the patient, what are they interested in doing? What do they think is achievable? What matters is, are we going to have success with it? And then consolidate that success, build on it, move on to the next thing.
Some people can't get out of the house, they don't feel stable or they don't feel safe outside their home. Something as simple as just marching in place. Put on your favorite show, get your knees up and march in place. So try to start where people are. What are the opportunities that they have? And then I really focus on anything is better than nothing.
It's really important to kind of keep things simple. You know, my mantra with my patients is eat less, eat smart, and move more every day. And then I try to break that down about how they can eat less, how they can eat smart, and how they can move more every day in the context of their life.
At our clinic, we use SMART goals, which are specific, measurable, achievable, realistic, and time-bound. So if I tell you I'm going to eat better, that is not a SMART goal. To know whether I achieved that, I need to tell you I'm going to only let myself eat sweets 3 days a week. And I can tell you whether I did that or not.
Every little small goal that you do, you feel good about, then you knock another goal down, and next thing you know, you got everything under control.
I started smoking when I was 13 years old. It kind of followed me my whole life.
Smoking today is quite different than it was 10 and especially 20 years ago. Many of the people who are able to quit have quit. What we have left is people with significant psychiatric comorbidities, significant nicotine dependence, strong cue response, some kind of barrier that's made it very difficult to quit. Tobacco treatment has been appropriately the domain of public health, and it's led to an enormous decrease in smoking. But it has led to a relatively formulaic approach. We now are shifting our emphasis to more advanced pharmacotherapy, more intensive evidence-based behavioral treatment, and we're really trying to individualize care.
Not only was I spending every month in the ER, it was every month at the dentist. My primary care doctor tried for months. He said, I'm not gonna push you, but when you're ready, let's walk through that door together.
There are two approaches for primary care docs. You can ask, advise, and refer them to a tobacco treatment program, or you can ask, advise, and then treat. When we're providing treatment, we really need to do two things. We need to get patients on pharmacotherapy, and then we also need to provide some kind of behavioral support. Tobacco use is intertwined with so many things in our day. I smoke after breakfast, I smoke when I get stressed, and for each of those associations, we have to identify the trigger and then come up with a strategy. The most common reason for relapse is that a trigger occurs and a person picks up a cigarette and smokes without ever knowing that the trigger had occurred. What we want to do is to find ways of decreasing the internal experience of that trigger. I say, each time you smoke, I want you to write down what you think the trigger was. We're going to come up with some strategies for managing those triggers.
My coach told me, when you get that urge, keep your hands busy. Get your mind off of it.
It's not the strategy itself, it's having something that breaks you out of an automatic connection. The new kid on the block that is very promising is adaptive pharmacotherapy. We start with a medication, we see how somebody responds to it, and then we change based on that response. As a physician, there is nothing more natural. The medications that are used to treat tobacco dependence fall into two big groups. One is nicotine replacement therapies, and then there's the oral medications. You have nicotine patch, nicotine gum, lozenge, nasal spray, and inhaler. And a very effective treatment for patients is combination nicotine replacement therapy. That means using a patch plus either nicotine gum or lozenge. Identify the triggers they have throughout the day and have a gum or lozenge proactively. Don't wait until you get an urge. Bupropion was developed as an antidepressant, but it's quite effective for smoking cessation. It also reduces withdrawal symptoms. It is very inexpensive. Varenicline and cytisinicline are kind of in their own category. Instead of reducing withdrawal symptoms, they block nicotine receptors, and you don't get a feeling of reward or satisfaction from smoking. Varenicline is our most effective medication. but it has some side effects, and now we're very excited about cytisinicline coming along because it works the same way but doesn't have the same side effect profile. Many people do not tolerate the full dose of varenicline, which is 1 milligram twice a day. If it's nausea that they had, I'll give them 0.5 milligrams twice a day. If it's sleep problems, I'll just give them a 1 milligram in the morning, and it is surprisingly effective.
I'm still climbing that ladder each day that I stay smoke-free. I'm proud of myself. I feel like now I'm just beginning to live.
That New England Journal article really proved to us that there is no such thing as too late when it comes to risk factor control.
We know that improving blood pressure or stopping smoking can be helpful at any phase of life.
When I talk to my patients about the why, I will often talk about, well, it's going to reduce your risk for heart attack or stroke. But I actually like positive framing much more, which is to say, we know that if we can reduce the cumulative exposure to your blood pressure, you're actually much more likely to live longer. But not only that, you're going to live healthier longer, which means more life in your years, not just more years in your life.